Hey Darshan, how you doing today?
I'm doing great, David. Thanks so much for having me.
It's wonderful to have you on. Tell us a little bit about your background.
Yeah, so David, I am a physician. I've been a physician now for almost 30 years. I can't believe it when I say that myself. But I went to medical school in University of Missouri, Kansas City, graduated when I was 21 years old and decided to become a surgeon at that point in time. I was a surgeon for 20 years or so before I started having my own personal kind of health issues, David. And I decided at that point to do a lot of research to try to figure out how to get myself healthy. So at that moment, when I found the miracle of kind of the longevity science world, of the functional medicine world, I realized that that's where medicine should be headed. And I changed my career completely into longevity and functional medicine. And so now I'm a longevity doctor, functional medicine practitioner, and we have a set of clinics throughout the United States called Next Health. What we do at Next Health is we help people who aren't necessarily sick. They go to their doctor and their doctor tells them you're fine, or they put them on a couple of pills for high cholesterol or blood pressure, and they're just kind of left to their own devices to just get sicker, right? Western medicine is so focused on treating us with pills and surgery. And what we
Mm.
try to do instead is to really dive deep, look under the hood of what's going on in someone's biology, and give them a plan to optimize their health so they never need to use medicines or surgery in the future, and they stay away from all forms of chronic disease. So that's what we do at Next Health. We call ourselves Health Optimization and Longevity Centers, and we have a pretty good process around that now.
I think this is so interesting because I find so many physicians are in such terrible health.
Right.
It's appalling to me. Like you guys know all about take care of
We
yourselves. It
don't.
doesn't happen.
Well, here's the thing, David. We don't know all about health. We know all
Mm.
about disease. That's what we
Oh,
spend years and years learning about is disease. In fact,
right.
our knowledge starts when you have the diagnosis of disease. That's when your typical Western medicine doctor's knowledge starts, right? Everything before that, nutrition, exercise, physiology, sleep, all of that is kind of like forgotten about because that is a domain of your dietitians, your nutritionists, your trainers, etc. So I actually, when I learned to get myself healthy, I actually became a certified trainer. I actually got my nutrition license so I could learn about these things for the first time in my life because we literally got 3, 4 hours of nutrition in medical school and zero on exercise.
Well, I will say in defense of Western medicine, when bad stuff happens, I'm really happy for the really highly skilled people, who can
Yes.
take care of it.
Western medicine is fantastic for once you have a disease and you're diagnosed, or you have a trauma, or you're
Mm.
sick with an infection. Western medicine, thank God for the advances in Western medicine. But, I always say Next Health is for the 95% of us that aren't sick, that don't need to be in the
Right.
hospital, that don't need to be in the emergency room. Where do we go? Where do we go to get optimal health? And what's incredible, David, is as you know, there's so much of that science that's coming out of Western medicine that we're applying to health now, and it's just supercharging people's health. And so that's what we do at Next Health as well, is we bring some of that technology to people that aren't sick.
One of the things I was really interested in having you on, Darshan, was to talk about this thing. It gets bandied around a lot called an executive physical. Like,
Mhm.
so what
Yeah.
is this?
So the executive physical is basically the physical that everyone should have, but they can't because insurance doesn't pay for it. Okay. So unfortunately, because people have to pay for it out of their own pocket, a lot of the people that are getting this physical are executives, CEOs, people that own their own companies that have the disposable income to do this kind of a thing. However, I will say that the prices of some of these testing modalities is getting lower exponentially year by year. And my hope is that insurance will cover it one of these days, and or it'll become extremely affordable for people. So right now, for somewhere between ten to $15,000, we've collected a group of tests that is super comprehensive and that we can use to literally detect all forms of chronic disease. So cancer, Alzheimer's disease, any kind of dementia, heart disease, heart attacks, strokes, all forms of chronic disease, we can detect it 20 to 30 years before it even starts. And what we empower people to do, David, is to become, I call it become the CEO of your own health. Understand what these biomarkers are, where you stand currently, and how you keep them optimized. So, all disease, David, develops over a course of time, right? It doesn't happen like immediately. And what you see in these blood biomarkers and scanning biomarkers is things slowly start heading in the wrong direction. Unfortunately, most people don't know it's been heading in the wrong direction for a couple of decades when they start getting symptoms. Our bodies are so resilient to symptoms that we don't feel symptoms until it's too late. A lot of times, the first indication that you have, that humans have for having heart disease, is their first heart attack. 50% of all heart
Hmm.
disease is diagnosed with the first heart attack, and 50% of those are fatal. So
Hmm.
the first symptoms we have of Alzheimer's disease is severe dementia. We let it get severe before we diagnose it. Same thing with metabolic syndrome. That now we have continuous glucose monitors, and a few people are using them, and people understand biomarkers like hemoglobin A1C and insulin levels. But for years, no one knew that they were headed down the path of diabetes until they started having vision abnormalities, until their toes started becoming purple from advanced diabetes. And so we have the technology now, David, to head off all forms of chronic disease. If you look at the CDC top 10 causes of death, like, their heart disease is number one, right?
Hmm.
Number two is going to be Alzheimer's and dementia. Number three is going to be cancer, and sometimes two and three are reversed, and then you have other forms of all forms of chronic disease, and all of these things can become orphan disease if people had more access to these testing modalities earlier in life. So we start people to get an executive physical when they're somewhere between mid 30 to 40. Some people want to do it earlier, which is fine, as you can never be too early with this kind of stuff. But that's where we start. And if you want, I can give you kind of a quick rundown of the tests that are included in the executive physical.
That was going to be my next question. So, cardiovascular disease, number one killer. Talk me through that. What are the
Yeah.
tests you're looking at?
Okay, so we're looking at blood biomarkers, right? Your typical ones of cholesterol. We use ApoB as the kind of the best marker of cardiovascular disease as far as cholesterol is concerned. But cardiovascular disease is not just cholesterol levels. I think there's so much controversy around cholesterol because people just tend to hone in on one thing. Cardiovascular disease has three factors associated with it. One is your cholesterol levels, but that's only after you look at inflammation levels and you look at damage to your vessel wall, which is due to high blood pressure. So those are three things that combine to cause cardiovascular disease. So we're looking at people's inflammatory markers as well. Inflammation is root cause of almost all diseases, and definitely cardiovascular disease is high up there in the list. Now, the test that we use to assess someone is we look directly at the blood vessels of the heart using an advanced CAT scan of the heart called the Clearly scan. Have you heard of the Clearly scan, David?
No, I've heard calcium CT scan, and I've heard what's the one I had done, like a sonogram on my
And the
arteries.
carotid arteries to
My
your neck.
Yeah,
Yeah,
yeah.
sonogram.
But I don't know about this. Tell me, what is this?
Okay, so the Clearly scan is an AI-enabled CAT scan of your heart that goes way beyond the calcium score. The calcium score is just adding up the amount of calcium that it detects around your heart and saying that you might have some calcified plaque. Here's the chance of you having it. What a Clearly scan does is it shows you every blood vessel in exquisite detail and how much plaque is along that blood vessel, both
Mm.
soft and non-calcified. So this is a scan that takes about 20 to 30 minutes. There is some radiation involved, so we don't do it very often. We do it as our initial testing modality for people with risk factors. But we can tell in exquisite detail exactly how much plaque you have and exactly where it is. And so I was just looking at a few Clearly scans a few minutes ago on some of our patients. And, we have a couple of patients that had no idea that had heart disease, and they have massive lesions in critical arteries. Some of these arteries are called widowmakers because these are arteries that,
Right.
first time you know that you have a blockage, you're having a heart attack. And so, it's a life-changing technology, and it gives you better and more information than even a coronary angiogram. So that's where, you go into someone's groin, you shoot dye in their blood vessels. Like, that's too much. You don't need to do that anymore. You can now do that with AI enabled scans of your heart. So it's super state of the art. They're about $1,000 right now to do this test, but I think if you can afford it, it's a great to have a baseline of a Clearly test.
And what are the biomarkers you're looking at for inflammation?
So we're looking at a bunch of different biomarkers. I mean, the basics are, of course, HS-CRP, highly sensitive CRP, but we also look at homocysteine levels. We're also looking at amyloid protein levels, fibrinogen. We have cytokines or interleukin levels. These are all levels that we're measuring to assess someone's true state of inflammation. CRP and homocysteine tend to rise later in the game when you have more moderate to severe inflammation. But those are both markers that every person, we empower our patients to know, like, this is what CRP means, this is what homocysteine means. You need to know what your levels are. You need to be comfortable that you're less than one, and so we watch those levels pretty carefully.
You brought something up with the Clearly scan. You're able to see hard plaque, so calcified
Mhm.
plaque, and
Calcified
then
plaque
soft plaque.
and soft
Is
plaque.
there is it possible to remove soft plaque at this point? I don't think you can remove hard plaque once that's there, but can you remove the soft plaque?
Yes. So now with the new PCSK9 inhibitors, there's
Hmm.
studies showing that you are actually able to reverse plaque with using intensive therapy, especially soft plaque, of course. And then, believe it or not, there's some studies showing even reversal of hard plaque, which is incredible with intensive therapy. So
Hmm.
I never promise that to patients. The goal is to stabilize a plaque. You want as the least amount of soft plaque as possible. So whether that's hard plaque or it's plaque in reversal, that's what you want. And what's great about the Clearly scan too is it tells you how much of that soft plaque is highly unstable. So unstable plaque is the one that gets a blood clot in it and blocks your blood vessel and gives you a heart attack. That's what you really want to know. And that's kind of like more of an emergency. That's when maybe you do need a stent put into one of those arteries. So, these are all concerns that people have when you're over 40 years old, but and definitely over 50 or 60. But the sooner you know, the better, because the sooner you can change your lifestyle and get on intervention, the sooner you can stabilize that plaque so it doesn't go in the wrong direction.
Let's go to cancer. You're doing blood biopsy and also scans.
Yes. Okay. So the state of the art for cancer for years, for like 50 years, ever since I went to medical school 30 years ago, all we had was colonoscopy, mammograms, and, like women would get an OBGYN exam. Men would have a rectal exam to feel their prostate for a hard lump. And then we had PSA, which is a marker of prostate cancer. That's all we could detect, really, right? Most other cancer, you didn't even know until it became symptomatic. Brain cancer, always diagnosed stage 3 or stage 4. Steve Jobs, pancreatic cancer, stage 4 when he started having symptoms. If Steve Jobs was alive today and he had an executive physical, he would have been saved from pancreatic cancer. And so, what people need to know is that even though you have to keep your colonoscopies up to date, you have to keep your PSA levels and your OB/GYN exams up to date, mammograms up to date, you're only picking two cancers there, two or three cancers. All of the other cancers, about 50 of them that are very relevant, that are not detected until you have symptoms. And so now the state of the art is combining a full body MRI scan with what's called a liquid biopsy. So we do both of those as well. So a full body MRI is going to detect earlier stages of brain cancer, pancreatic cancer, liver cancer, et cetera, that you would have never known about until they became symptomatic. And then the liquid biopsy detects cell-free DNA. So this is DNA being shed from active cancer cells that is migrated into your blood, and now we can detect those with advanced DNA sequencers. So now we know at stage 1 or 2 a lot of these cancers, if they're developing in you or not. So that's kind of what we make part of our executive physical. And look, I mean, there's, for people who know about this kind of stuff, there's always a controversy of, well, what if you get a false positive? What if
Mm.
something shows up and you don't know what it is? And so I always have the conversation with my patients beforehand, is like, look, we have to be able to be in a mindset that we can tolerate the potential negatives of a false positive, which is mainly just stress and additional diagnostic testing, versus the potential positive of detecting a potentially fatal tumor or anatomical abnormality at stage 1. Right. And so that's kind of what we talk about with our patients, to make sure they understand both the value and some of the psychological risks that occur with advanced testing.
Are you able to remove some of the false negatives or false positives because the synergistic interaction of the blood-based biopsy with the scan?
Absolutely. And we also use our blood tests. We have a lot of testing modalities that we do. We do 1,000 different blood biomarkers as well, genetic testing as well. And so we can, we paint an overall picture, both with symptoms, testing, traditional testing, and advanced testing paints an overall picture for us.
I'm just curious, what size of mass is able to be detected with the scans?
As small as less than a centimeter in diameter, you can go, even 5 millimeters in diameter, you can find cancer masses as well. A lot of it has to do with how the MRI uses a special technique called diffusion weighting. So it can actually provide a visual representation of how tissue feels, believe it or not. And so if something feels hard, it'll light up on these scans, even if it's a tiny tumor. So it's really interesting how this technology works. But yeah, we can detect pretty small tumors.
Well, let's talk about the other biggie, Alzheimer's. Functional testing, what sort of test are you looking at there?
Right. So we do some functional testing. We do a cognitive brain test online for patients that are experiencing potential symptoms of cognitive impairment, right? So it all starts with mild cognitive impairment, and we take them through a questionnaire. If they're unsure, then we'll put them on a computer that does some testing for them. But in reality, there's not great testing for Alzheimer's until just now. So just in the last 1 year, we now have blood tests that can detect tau protein and amyloid protein in your blood. If you know, these are the proteins that are involved with Alzheimer's disease. We can now detect these in the blood. And the initial studies are showing a high correlation with the PET scans, which are a specific kind of high radiation scan that we use to actually diagnose Alzheimer's. So there's a great correlation between a positive blood test and these PET scans. So even though they don't say, the testing companies don't say, and there's needs to be a lot more research done on preventative testing of blood biomarkers for Alzheimer's, we're still doing them to give us an indication, and then we'll go down a diagnostic pathway if something comes up positive.
So let's move on from the scary stuff. All the stuff we really don't want to find. Optimization. Before we started, you were telling me that you're doing therapeutic plasma exchange, which you're actually the first clinician I've spoken to who does that.
Yeah, so just take a step back, David, if you don't mind. When we
Yeah.
talk to our patients, I always tell people that we have a few different goals in mind. Our first goal is to optimize along the most common things. We need to make sure your nutrition, your exercise, and your sleep is perfect, right? And so as close to perfect as we can get it. Most people have not even had a great education around those type of around nutrition, sleep, and exercise. Most of your audience is pretty advanced, but we empower people by using things like continuous glucose monitors, sleep monitoring technology, whether it be an Oura ring or a pad, and we put into place VO2 testing, grip testing, et cetera, to really understand where they are on those basic aspects of health. Then the second part is the scary stuff that we talked about, is ruling out anything that could potentially kill you. And the third part is where I love to be with patients, is the functional medicine, treating disease at its root cause. So this is functional medicine. That means improving gut health, improving your hormonal health, improving your emotional and brain health as well, and detoxifying your life. So around those four different aspects of functional medicine is where we do a deep dive with blood testing, and we see where their markers are, and we put into place habits and therapies to really optimize along those four aspects. And then once we have all that right, we can talk about some of this advanced longevity technology that we use on site. Because we want to get all that right first, right? Like, you don't want to start doing plasma exchange and stem cells if you're not, if you're going to McDonald's every day and you're sleeping 4 hours a night. It doesn't make sense, right? so we want to make sure we're really getting you the maximal result, and you're not basically wasting your time or your money on this. Therapeutic plasma exchange is a new procedure that we just started doing as well, about 8 months ago, for longevity and health optimization purposes. But to be clear, this has been FDA approved for 2 decades, and we've been using it in the hospital for disease states, such as an autoimmune crisis, for example, is one disease state that we use it for. And what therapeutic plasma exchange does is we put an IV in one arm, we remove your blood and your plasma, we put it in a giant machine that looks like a dialysis machine, and it separates the plasma from the blood. So then in another IV, the blood goes back into your arm, and then that plasma is totally removed. And I always say the bad stuff lives in the plasma, right? So you have your immune complexes, you have your inflammatory mediators, you have your cytokines, inflammatory cytokines. All this stuff lives in the plasma, and your body is working so hard. Your liver, your kidneys is working so hard to eliminate these toxins. What this machine does is just physically separates it completely, and we remove it and we throw it away. And we replace that plasma with fresh albumin and IV fluid. So your body can regenerate the positive things that need to be in plasma, like clotting factors, hormones, etc. All that regenerates within 24 to 48 hours, but all the bad stuff takes months or potentially years to eliminate. We're removing it with therapeutic plasma exchange.
So with something like therapeutic plasma exchange, I'm guessing there are markers that you're comparing is to judge success. So before and after, what would you be looking at?
Yeah, same. We're looking, it depends on what we're doing it for. So if we're doing it for longevity, we're actually testing a methylation age,
Mm.
before before the treatment protocol begins, and we test one at the end of the treatment protocol. We're measuring inflammatory cytokines as well. So a lot of people are suffering with inflammation, and we're measuring those as well. Some people are suffering from like heavy metal toxicity, so we're measuring heavy metal levels as well. It just depends on what we
Mm.
see in the blood that's abnormal that we want to affect a positive change in. Now, some people, they're like you, David. They're like this model of perfect health, and they come in and they still want to have it done. They're like, I want the latest technology. If it's not going to cause any harm, why not? And so, really, the only thing we can monitor in someone like that is their methylation age, and we've seen
Mm.
tremendous changes in people's biological age, even just with one treatment. So
Mm.
it's really I'm really excited about some studies coming out this year on massive biomarker changes and especially biological age changes with therapeutic plasma exchange. We're going to be seeing a lot of research being published this year on that.
All the people that I've spoken to about it, I find it absolutely fascinating that you just like strip out not even all the plasma, but a section of the plasma, and then you have these amazing results. And it sort of brought me like, well, maybe the poor man's version of this is just donate a lot of blood all the time. And you're, I don't know.
Right. Yeah, well, unfortunately, you can't donate this much blood because you get in trouble. It's severely anemic. But a lot of people do have positive health effects from blood donation. As you know, it raises your erythropoietin levels as well. So I think, plasma exchange right now, it is slightly expensive, but it's not going to be forever. And I think the more research we see coming out for it, the more mainstream it'll get. The more mainstream things get, the lower the price gets. So I'm excited to see where this kind of leads us. And it's so funny to think that maybe, the solution to aging, one of the solutions to aging and inflammation has been under our noses for decades in the hospital, and we just weren't using it.
Wouldn't be the first time.
Yeah, exactly. Exactly.
Um, so you mentioned hormone optimization, which I'm not a doctor and I'm not a scientist, but I find the whole hormone thing incredibly complicated. Therapeutic plasma exchange, okay, that's pretty straight ahead. But this stuff is like, wow. So if I came into you, I'm 65, say I'm feeling like, and I don't want you to be my doctor here, but like I'm just going to make this up. So
Yeah, go
I,
for it.
I think like, well, maybe I don't have as much mental acuity or my recovery in the gym takes a little longer. What's interesting to me is there's sort of like various ways people do this. They'll just like give somebody like, okay, here, try this gel. We'll see how you feel. And there are other places where there's like a lot of testing going on. With a male, what are you looking at in terms of hormone markers?
Yeah. So first of all, if you go to someone that gives you a gel and says, "Take this and see how you feel," definitely that's a red flag. That means they're just, it's another one of those like, I hate to keep bagging on Western medicine, and most Western medicine doctors are much more advanced now than this. But it used to be when you had 10 minutes to see a patient and they told you this and the testosterone level was low, you just give them a bottle of gel and see you later, and absolutely that's not the way to do it. We do an in-depth hormone panel on men and women. It includes things like testosterone, free testosterone, sex hormone binding globulin, and also, you have to measure everyone's PSA level when you're doing hormone therapy. You're measuring estradiol levels. You're measuring thyroid levels, everything. So we get a complete hormonal picture. Now, David, for someone like yourself, since you gave me the example, I will tell you that if your testosterone level was low, and I say low in quotes, because a lot of it has to do with your symptoms, then we would talk about testosterone replacement therapy. Now, there's ways to increase or boost your testosterone naturally, as we all know of, lifting heavy weights, ashwagandha, DHEA. There's other things you can do that, but it probably wouldn't get your testosterone level up too much. And we like to see men have a testosterone level that mimics kind of like where you were in your 20s or your early 30s. Okay, so for most men, that's somewhere above 400 for sure, but somewhere around 5 to 900, somewhere in there. So we go very much based by symptoms, David, and we're following your hormone levels on almost a quarterly basis for a couple of years until we get things exactly right. Now, we have different modalities of treating testosterone, low testosterone. One is by taking a pill that encourages your normal natural production of testosterone. That's called Clomid. That can probably get you up about 100 to 300 points. Another method is by using testosterone injection therapy. And with that, it's very important to do at least twice a week. We prefer 3 times a week dosing, so you don't have these massive ebbs and flows of testosterone. And then the last way that I like, that I use personally, and I like for a lot of patients, is testosterone pellet therapy. That's where we put a small pellet of dissolvable testosterone under the skin of the buttock, and it takes a little procedure once every 4 to 6 months, but it basically lets me forget about having to inject myself with testosterone. This is letting me have small doses of testosterone every day without having to inject myself. So those are 3 modalities. We almost never use testosterone creams on anybody. I can't remember the last time I prescribed that, just because the absorption is so variable, and it's, can get on your loved ones, it can get on your pets, and people forget all the time to put it on, all of that good stuff.
I'm curious with the pellet, do you get a surge in the beginning or is it even?
Yeah, so the first time that you do a pellet therapy, and maybe even the second time, you'll have an immense feeling of a surge. And that's because your testosterone has been low for so long that now it's finally normalized, your body feels it. But after the first or second time you put the pellet in, no, it's a very controlled release, and it keeps you at a really, it increases over 6 weeks, and then it's pretty steady over the next, 3, 4 months. And I don't feel a surge, and I think most people feel pretty good after doing the pellets, after they've had a couple of, rounds of it.
Mm.
Yeah.
I've been hearing, much lower doses of testosterone replacement therapy for women.
Yeah. Yeah. A lot of women use testosterone replacement therapy. And in fact, for a lot of women, that's all we use is testosterone replacement therapy, if they're, premenopausal. So women are a little bit more complex, just because it depends on what stage they're in of their cycle when you evaluate them, and also what stage of life they're in as far as pre, during, or postmenopausal. So we really try to tailor the hormone replacement therapy towards where they are.
Tell me, what are you excited about bringing in to your clinical practice that you can't right now?
I'm excited about so many things, and unfortunately, our FDA makes it really, really hard to do things that they they should be approving, just so that the United States can stay ahead of the game on patient care and medical technology. However, they are not approving, and they're putting roadblocks in place because of the intervention by pharmaceutical companies, that they can make money off of these things. You know what I mean? So things such as stem cell therapy, exosome therapy, peptides. The peptides is such an exciting field. There's so much we can do with peptide therapy. We see that right now with the peptides Ozempic and Mounjaro. Like, what is game changers for the world, right? There are risks, of course, but I've been using peptides for years now, things like BPC 157, CJC, et cetera. And now the FDA is putting more restrictions in place on these peptides. So I think there's a lot going on in the world of longevity that, unfortunately, our FDA is trying to block. But, The research continues to go on in other countries, and it will continue to flourish, and we will be able to do a lot of these things here at some point, whether it be in the United States or outside. Now, there is a lot of talk right now about gene therapy, and you might have heard of follistatin gene therapy, and I think that's definitely an incredible new frontier. Follistatin is just one gene. Of course, we can do thousands of different genes if you theorize along gene therapy what can potentially be done. But I think follistatin is a good place to start because it's a reversible type of a thing, and also you can the effects are simply just muscle growth. And we have the biohackers trying this out right now. There still needs to be a lot of research done, but I feel like it's going to go in the right direction where we'll see more gene therapies coming out, and also it becoming more standardized and more available to people.
I'm really big on testing and monitoring. I do some of the things that you've mentioned. I'm hearing what you've just told me. I'll probably do more.
Yeah,
Basically, I don't want to die.
right, exactly.
So, but it's sort of a shame that people go and they'll get a physical like once a year, and they're not even checking people's vitamin D levels. They're just like, it's puzzling to me. I wish that more of this was covered by insurance, and there was more oversight on people's health, because as you said, especially with like the two biggies, cancer and heart disease, it's really about what are you seeing early on. Once a cancer mass gets to a certain level, like it becomes, it just, you're looking at 10,000, 20,000 different forms of this, and that becomes really difficult. And the same thing with
Yeah,
cardiovascular disease.
I mean, it's just mind blowing to me that treating cancer cost upwards of $250,000 to $400,000 a patient, whereas giving everyone in the country a genetic test that you can get, if you really do this at scale, you could do it for $50, $100, uh, on a yearly basis, you'd avoid so much healthcare costs and also so much pain and suffering, right? And the same is true for heart disease. And, calcium scores are not approved by insurance. Like, to me, that's like
Right.
the most
Yeah.
underutilized test in all of medicine. Like, you could find so much advanced heart disease with calcium scores. And they're only like $100. Like, why not
Yeah.
approve that? Right. And these blood tests for Alzheimer's, same thing. Like, they're going to come out and they're going to probably be a few $100s to start. But I'm sure, doing those at scale and detecting Alzheimer's at an early stage is so valuable. And then, I do think, though, that we do have some good testing now for metabolic disease. And metabolic disease is the base of a lot of
Right.
these other diseases. So if you can keep your insulin levels under control, then you will be way ahead of the game. You have much less risk of Alzheimer's, cancer, and heart disease. And the best way to do that is to know what your hemoglobin A1C level is. So that's a blood test that every doctor should be able to do for you, and it costs basically $1 or $2. And if your hemoglobin A1C, I always tell my patients, every patient, you need to know what your hemoglobin A1C level is. I should be able to ask you. You should be able to tell me what it is. And I know you probably can, but most people can't.
4.7.
Right. There you go. 4.7 is an
Yeah.
incredible goal to have. So I tell people, you want to be 5.2 or less, but if you start edging up 5.4, 5.5, 5.6, you're going in the wrong direction. We got to do something about your diet, your exercise, your sleep to get you back into where you
Yeah.
need to be. So, and that's just an easy, cheap test that almost everyone has access to. And if your doctor's not doing it, I would insist on it. Same with HSCRP. Inflammation is another, root cause of all disease. Everyone should know what their HSCRP is.
I don't actually know what the number is off the top of my head. I have it in my
Probably because
phone.
it's zero. So,
I know it's pretty low. Yeah.
yeah,
One of the things you said early on was sort of the basics. What I tell people, like, you got to get the big rocks right. So that's sleep. If you're not sleeping, you're sabotaging anything else you do. You got to sleep. Figure it out. Go see somebody, get that
exactly.
figured out. And, what are you eating? What are you bringing into your body? And then how are you moving? Like, if you sort of get that more or less figured out, okay, now we can talk about the exotic stuff. But, like, you got to get that done, or the rest of it not going to work so well.
Yeah, and David, you know what I always find when have that talk with my patients and just even my friends and family is that people get so hung up on the little details. Like, they read tomatoes are bad for you, or they read, and they get so hung up and then they get like paralysis by overanalysis, and I say,
Yeah.
let's look at the 20% of the information and the routines and habits is going to make 80% of the difference. That's
Yep.
the Pareto principle, right? And it's so
Right.
simple with sleep, exercise, and diet, what that 20% is. Like, just get that right, and
Yeah.
everything else is a bonus on top of that, right? So avoid ultra processed food, right? Like, that's to me is like step one, two, and three of getting your diet right. You can pretty much eat anything else, and ultra processed food is step one. And step two on diet is maintaining a flat glucose curve. And the way you do that
Yeah.
is reduce your refined carbohydrates, your refined grain intake, eat your carbohydrates last in your meal, don't snack. Done. You do that, you're automatically going to be healthier than most of your friends. I hate to say. And yeah, I mean, we could say the same things about exercise and sleep. Keep moving. Don't be sedentary. That's a massive problem that we have in our society nowadays.
Yeah. I could go on and on about that, but
Yeah. I'm on my walking desk right now, David. I turned it off for a
oh,
minute.
good for you.
Oh,
That's
I get
great.
15 to 20,000 steps in a day. It's amazing.
Walking is just the best. Darshan, this has been wonderful. Thank you. I've always sort of wondered for myself. I mean, personally, this podcast is really just about informing me about
Mm,
stuff and other people listen to it.
yeah.
So I was really curious about, what exactly happens in something like if somebody goes to see you at Next Health, like with an executive physical, what are we looking for and what are the solutions there? Like if we find something, okay, that was good.
Yeah, yeah. And so that's what we do. I mean, you come in, the executive physical takes about 3 hours to do. And then takes a couple of weeks for us to get the results, but then we sit down with you over 2 or 3 sessions and really make sure you understand what we're looking at, and like I told you, we have this kind of paradigm that we use of the wellness wheel, which goes over the 12 aspects of health. And then we develop a plan for you. And a lot of the technology that you need to keep yourself healthy, we have it on site. And people come in on a regular basis, weekly basis to use it. And then we just rinse and repeat on a yearly basis.
Wonderful.
Yeah.
Darshan, thank you so much for your time today. I know you're a really busy guy, and we were trying to book this for a long time, and it's been really nice to see you and have you on.
Well, thank you so much for everything that you're doing, David, informing the public and doing the podcast and asking the best questions. And I'm sure people learn so much from your conversations. So thank you for what you do.
Thank you so much. Great to see you
Yeah.
today. Mhm.
Take care.
Bye now.